moving up. Start video. All right, everybody, we're just gonna take a couple more minutes because there's a small technical issue that kept people out. So just give us another 2 minutes for everybody to get in, and then we'll start. Thanks. We haven't started yet, so just 2 more minutes, and then. Oh, where'd I go? All right, good evening, everybody. My name is Jeremy Wimpheimer, and I'm on behalf of Sohar. Thank you all for joining us from around the world. Just a bit about our program, Sohar ועשרים, Sohar 320, was launched as a program of the Sohar Center for Jewish Ethics with a vision to help people and families at some of their most vulnerable moments, and with the understanding that respecting our parents and loved ones, particularly in the toughest of times, is a core Jewish value. We do this, we embrace these values by bringing together rabbis with social workers to help navigate these deeply complex issues that we will be discussing tonight. Before we begin, I just want to thank our co-hosts, the AACI, the Association of Americans and Canadians in Israel, and I'm proud to introduce the Executive Director of the AACI, David London, to present some remarks before our event. Thank you. David. You can unmute yourself. There you go.
Good evening. Again, on behalf of AACI and Sohar, we welcome everyone. My name is David London. I'm the CEO of AACI, and tonight's program, Through 120, or Ad ועשרים, dealing with the end-of-life issues, unfortunately speaks to me. Almost 20 years ago, I lost both my parents about 8 months apart, and the questions and the thoughts that come here are questions and thoughts I think that a lot of us have and a lot of us deal with. I want to first of all thank Professor Charles Sprung, Rabbi Cherlow, for conducting this seminar on this very important subject. We're very happy to see that the marketing that was done very successful. Last I looked, there was over 400 people participating from all over the world. And before we start and I turn it over, I just want to also offer my condolences to Professor Sprung on his loss of his wife. So where the speakers are coming from is a place of knowledge and feeling. Good evening to everyone, and let's meet on happier occasions as well, too.
Thank you very much, David. So I just want to, just in terms of the format, we're going to have two separate sessions. How do I? Okay, we'll have two separate sessions where, one moment. And at the end of each session, okay, thank you. At the end of each session, we're going to open up the panel for questions. Your questions should be posed in the chat, and we'll try to get to as many questions as possible. And so with that, I'm not going to take any more of your time, but I'm going to introduce Professor Charles Sprung, who is the Director Emeritus of the Intensive Care Unit at Hadassah Hebrew University Medical Center, a person with decades of both clinical experience relating to the caring for the elderly and the severely ill, and as he will detail this evening, a deeply personal story that gives him a valuable insight to these issues. And he will be followed on the panel by Rav Yuval Sherlow, who is the Director of the Center for Jewish Ethics here at Zohar. And with that, Professor Sprung, the Zoom is yours.
Thank you very much. Good evening. Tonight, we're going to cover two topics that I've been involved in for many years: advanced directives and nutrition at the end of life. My goal is to help you develop some practical tools and skills to navigate some of the most difficult decisions you'll have to make during your lifetime. This will be a mixture of professional and personal reflections. Professionally, I've been working in intensive care for more than 40 years, helping patients and families deal with end-of-life issues. Personally, a little less than 3 months ago, Rebecca, Zichrona Livracha, my wife of 49 years, died after a long illness that involved many of these concerns. Tonight, I will wear both hats and provide insights in terms of what we went through over the years. Why is it important for you all to be prepared? Most people have no idea what their loved ones would want at the end of life. Too many people are afraid of having these discussions, and too many people die in a way they would not choose, not infrequently suffering, which could have been avoided. It is extremely important for people, especially those with chronic illnesses, to have discussions with their families and friends about their desires for end-of-life care. Have you had these discussions? If you had a terminal illness, would you want to be admitted to an intensive care unit, put on a respirator, or have CPR? Have you discussed this with your family? In our recent Ethica study of approximately 200 ICUs in 36 countries, only 19% of patients had decision-making capacity, and only half were patient desires known at all. Now, there are legal mechanisms in Israel and around the world that help document individuals' desires for end-of-life care. These include advanced directives for people who can no longer make decisions for themselves. Most people do not have advanced directives. Getting prepared for this talk, people told me that they've got the papers, but they didn't fill them out. We've got to do more. Many of you are probably asking yourselves, what exactly are these advanced directives? Advanced directives include a living will or a durable power of attorney, which in Israel we call an ipoi koach. Now, if you look in the chat, we're going to put on the links to the Ministry of Health advanced directives in English. Many of you, the Hebrew won't help too much, but you do have to fill these out in Hebrew and have to send them back to the Ministry of Health. You can write down the links, you can take a picture, but we'll also provide these links for you later on so that you can use them. Now, the advanced directives are completed at a time an individual is mentally competent and able to make a decision for a time in the future when he or she may be unable to make decisions. A living will is a legal document that states the types of medical treatments someone wishes for their end-of-life medical care. A durable power of attorney, or an ipui koach, is also a legal document, and it allows a person to pick someone, a family member or perhaps a close friend, to make medical decisions for them if and when they can no longer make the decisions for themselves. Differences between these two legal documents include the fact that the ipui koach allows a person to assign someone that they choose to make the decisions for them, whereas a living will only has the statements that the person has made. The ipui koach, or power of attorney, does not indicate the medical treatments the individual would want, so it's extremely important for the appointed person to discuss at length what that person would want under different medical circumstances. Also important is the appointed ipui koach agrees to respect the person's wishes, because if they cannot, they should not be the surrogate decision maker. Now, approximately 5 years ago, in June 2017, Rebecca was diagnosed with stage 4 non-smoker's lung cancer and started treatment. After first hearing the diagnosis, our family started a personal journey of what Rebecca wanted and what she considered best for herself. Now, I have the dual role tonight of also being the projectionist. So I will show you a picture of Rebecca here a few years ago in the Golan during one of our Pesach vacations. Now, after caring for patients and researching issues related to end-of-life decisions for so many years, you would think it would be easier to deal with the problem when it involved my wife, Rebecca. No matter how much experience and knowledge I had, helping make decisions and caring for Rebecca was very, very different. Both Rebecca and I had discussed our choices for end-of-life treatments soon after the terminally ill law was enacted in 2004, much before her illness. Each of us was the ipui koach, or surrogate decision maker, for the other. Interestingly, my desires for treatment were more aggressive than Rebecca's. Once the cancer was diagnosed, we discussed if any of Rebecca's desires for treatments had changed, and she said they really had not. At that time, despite her cancer, she still wanted to be admitted to an intensive care unit if she was critically ill, undergo intubation and ventilation, or put on a respirator, and even undergo CPR if necessary. In September 2018, the cancer progressed, and Rebecca required intravenous chemotherapy, which she received every 3 weeks for more than 3 years. Many of our friends had no idea she was getting chemotherapy. She looked as good as she looks in the picture, and many people didn't even know she was ill. Now, in June 2021, the cancer progressed again and required another change in chemotherapy. At this time, we decided to reevaluate our end-of-life decisions and change our ipui koachs. Rebecca was not improving, and I was already past 70 and not getting any younger. We had a lengthy discussion with all our 4 children as to who would be our new ipui koachs, or surrogate decision makers. We all decided on 2 of the children as the best choices for our surrogate decision makers for various reasons. Most important, Rebecca and I discussed what each one of us would want, given the changing circumstances. I wanted exactly what I had previously wanted, and I made sure to specify exactly what this was for all my children, but especially the 2 new surrogate decision makers, so they would know exactly what my desires were and there would be no problems in the future. As Rebecca's condition was worsening, it was important for all of us to know exactly what she wanted. As our youngest daughter had married several months before during the COVID pandemic and was now pregnant with her first child, Rebecca had told her oncologist that he had to keep her alive so she would be able to hold her new grandson. She therefore decided that she would still want to be admitted to an ICU, be on a respirator, undergo CPR, just to make sure she'd be able to hold that new grandson. Thank God Rebecca lived to hold her new grandson, attend his breast, and watch her daughter become a wonderful mother during Rebecca's last few months. Now let me take this picture off and put on a new picture. Which I can't find. There, do you see that? Hopefully that's shared, and you can see this is a picture of the Sprung clan with Rebecca holding her 12th grandchild at his breast.
Yeah, Professor Sprung, you have to share your screen. You have the picture up, but you didn't click on share screen at the bottom.
Okay, that's not working. Guess we have to get a new projectionist.
All right. We'll find it.
Nope, that's the wrong one. Anyhow, we're gonna. I don't want to take too much more of the time if it's not working. Maybe we can put it on a little later. But in any case, Rebecca did make it to the bris, and will be a picture eventually, perhaps, of her holding the baby. Interestingly, a few weeks after the bris, our daughter requested that we have another family discussion about what Rebecca's treatment desires would be now that she had held the baby. So we had another meeting with all the children, and Rebecca let us know at that time that as she had held her grandson, if she deteriorated further, she would no longer want to be admitted to an ICU, be on a respirator, or undergo CPR. These open, straightforward discussions were very personal, intense, and sometimes even painful. They were difficult for all of us, and I'm sure I made some mistakes. Having our children participate in the process helped to not only clarify for them what our wishes were, but also helped us with the decisions that we had to make. I can't tell you how many times over the years I've seen end-of-life issues and disagreements tear up families. Our family end-of-life discussions with sensitivity, respect, and true listening brought us all much closer together than we had ever been before. So my main points for this session is that most people do not have end-of-life discussions, and their families really don't know what they want at their end of life. These discussions and advance directives for end-of-life issues, a living will or a durable power of attorney, are important so autonomous wishes of individuals are ascertained and, more importantly, respected, and they receive the treatments they desire and do not suffer. I personally prefer the ipui koach as it provides more flexibility, but again, it's important to make sure the appointed surrogate understands exactly what the person would want under the different circumstances. As seen by Rebecca's situation, treatment decisions may change over time with changes in the medical circumstances, necessitating additional discussions and sometimes even changes in the advance directives. Most important is to have the entire immediate family hear from each person what their desires are for end-of-life treatments and respect them. Even if family members have different opinions about what is best for their loved ones, they will usually respect what their relatives requested. If they cannot respect their wishes, they should not be surrogate decision makers. If done right, family end-of-life discussions can bring families much closer together. Thank you.
Thank you very much, Professor Sprung. So now we'll turn to Rav Shurlo to give the ethical and halachic perspectives on these issues. Rav Shurlo.
Shalom to everybody. What is the role of a rabbi, of the rabbi, in those issues of preparing ourselves and making decisions and giving pre-orders in order to make our end of life in the right way? Actually, he has two missions. And we in Zohar Le'etika, the department in the Center of Ethics in Zohar, are dealing with both missions and targets that we have. The first mission is to clean the table, because there are many people that think that it's the wrong thing to speak about death, to prepare yourself. And they have all kinds of quotes in order to prove that actually they are right. They can quote, Al tiftach pe l'satan, don't open your mouth to the devil, because once you speak about those issues, the devil is here. They can quote, אפילו חרב חדה מונחת על צווארו של אדם, even if there is a sword on his neck, he shouldn't give up, he shouldn't ימנע עצמו מן הרחמים. And those are all kinds of quotes that are very important, and they have a lot of, they are really empowering ourselves, and they give us a lot of hope, but they shouldn't stand and shouldn't be a wall between us and preparing ourselves. Actually, the halacha really designed a very excellent way in order to balance between hope and reality. The halacha says that when someone is really close to his death, we should offer him to confess, to make a vidui. But we are concerned and afraid that saying that will really give him a slap on his face, and he will be completely without any hope, and maybe it will harm him. So there is a sentence that say, you better confess, but you should know that many people that confess actually lived even longer, and it doesn't say anything, and it's a kind of a balance between those both two missions. One is preparing, and one is having the hope and the courage and the power in order to face the future, and nobody knows how long will it take and what will happen. Taking this sentence or this halacha that is regarding specifically to confess, and making it is making this sentence as a ideology of the whole issue of giving orders in advance is the right thing to do. And this is the first mission, as I said, of the rabbi, telling people that you shouldn't see preparing yourself and giving orders as something that is opening a door to the devil, or something that is actually is not according to your faith and the belief in Hashem that they can do everything and there are miracles or whatever, but it's a kind of a balance, and that's actually what we are doing all our life, trying to balance between reality, ability, courage, power that we have, and our belief in God, and understanding that not everything depends on us. רבות מחשבות בלב איש. Many people are thinking of all kinds of ideas, ועצת השם היא תקום, but actually what Hashem decides will happen. And we always have to balance between those two factors. And this is, as I said, the first mission of the rabbi, cleaning the table and trying to rescue people from using or from soaking in all kinds of ideas that are actually faith in empowering ourselves, but actually they are stopping people to face the fact that all of us will die in the end. The second mission is not cleaning the table, is not trying to confront mistakes, but actually there are many questions about what is appropriate to say in advance. Can we say in advance that if someone, if I stop breathing, I don't want to be ventilated? We'll speak in the second session about feeding. Can I say that I don't want to suffer? And if I'll have a lot of pain, I insist that I'll get any kind of an injection or medicine, even though there is a sort of a risk that it will shorten my life. And these are ethics and halachic questions that are on the table. And I don't want to clean them. I want to discuss them. It's very important to know that from one hand, as long as we are able, we should not give up. And we should understand that every minute of life is important until one point. And from another point, the halacha recognize the idea of the palliative care, and a person, and many times the family, can say enough is enough. And instead of suffering, instead of being attacked by the staff, by the medical staff, we should let ourselves separate and say goodbye and be relaxed and silent when we have all our family around us, and not being a kind of body that everyone is trying to do something that actually is full of pain and full of suffering. The halacha has answers and has instructions. And from one side, there is a very important thing that the halacha insists that will not do anything active in order to shorten life. But for the other hand, we should change the image of halacha, and we should understand that the halacha permits to say in advance, if this will happen, if I'll get to this point that actually there will be no value to anything I do, I want that nobody will try to expand my life in a artificial way, and let me say goodbye, let me prepare myself, let me confess, and let me go to the olam haba with silence, without pain, and without suffering. Now, writing those orders is a halachic issue, because, as I said, there are things that are permitted, there are things that are prohibited. Doing active things is something that the halacha doesn't permit, but stopping and not expanding life and letting ourselves to go and die in silence is a very important value of halacha. And in some of the cases, the halacha even says that you are not permitted to do anything when someone is dying and you really want him to stay here and to be part of us, but you are not permitted to do that because it's not the good thing for him. So if I'm summarizing, I think that we, as the center of the ethics of Tzohar and rabbis, are having two missions. One is, expelling the mistakes that people do because of faith. And the second thing is to together to have instructions, what is permitted, what is not permitted, what can you do, what you are not able to do, and preparing ourselves and giving orders in advance. But the most important thing, as Professor Sperling said, and the only thing I can do is, to echo his words, it's very important, because the halacha recognize our willing, our wishes, what we want. The halacha doesn't say everything is objective. There is a major part of the subjective of our decisions, and therefore we do support, and I think it's very important to do everything that we can in order to give instructions in advance in two ways, one of two ways. One is giving our personal instructions, or having someone and appointing someone to make the decisions when we will not be able to make them by ourselves. And I think that it's a big, wake-up call for everyone to give those instructions in advance, and then if worse come to worse, and we reach this point that we cannot do anything anymore and we cannot say anything anymore, the staff, the family, and everyone that is surrounding us will know exactly what actually we wanted, that we want that things will do with us.
Thank you very much, Rav Shurlo. So now we'll take some questions that were posed on the chat. And if you have any additional questions, either now or for the next session, please write them in the chat. So the first question we have was for, does the durable power of attorney designee need to live in Israel, or can it be a family member who is not a citizen of the country?
So I don't know specifically the answer to that question, but if you put in a family member as the ipui koach, it really shouldn't matter if the person lives in Israel or not. As part of the terminally ill law, I mean, the advance directives are important, but for the first time, a family member who had spoken to someone, even if there is no legal document, there's no advance directive, or if there's no ipui koach, the discussions that a family member had with the person who is now incompetent would also have standing to help doctors make decisions. Prior to the law, there was no legal standing at all for a family member. So even if someone is not a citizen of Israel, if they have had discussions, and clearly if that person is the surrogate decision maker for the person who's an Israeli citizen who's sick in an Israeli hospital or in home care in a kuppah, their statements, knowing what the person would want, would be important, and the doctors would be very, very glad to get that information to help make their decisions.
Okay, so on the chat, there's some debate on it, but there's an attorney who says that under recent changes in the law, it now can be a person who lives outside of Israel. So I guess we're not going to give legal advice, but that's what's
actually, it makes sense. I mean, it doesn't make sense that only someone that lives in Israel and is a citizen in Israel can make the decisions. I mean, you know, now I'm not saying that every time and always the law makes sense, but from the ethical point of view, I can't see the idea why only Israeli citizens or someone that lives in Israel can do that.
The biggest problem is we don't know what people want. And if we have information from a family member, wherever that person is, who can tell us what that person would want, what his autonomous decision would be, then that's important information that we should be able to use. I mean, that's ethical and certainly medical and certainly part of the terminally ill law.
Mm-hmm. The next question is, it's a very practical question, but Professor Sprung, I'm sure you have experience in this. The question is, even if all forms expressing the patient's wishes are completed, how can they reach the physician at the moment of death?
Well, part of the process is to fill out all these forms and then to send it to the Ministry of Health. So if all these forms are at the Ministry of Health, usually when someone is admitted to a hospital, the physicians, the nurses will ask if they have any advance directives. And if they have them, the family members should bring them so that they see what they are. But because they are in the Ministry of Health, the Ministry of Health can provide this information to the physicians in the hospital also.
It's very important to emphasize that the problem is not with the physician. The problem is with the ambulance that is coming and from the Hadar Miyun, emergency care, that they don't have the time, and they are not they don't ask all those questions. So therefore, if someone has instructions in advance, the whole family should know about it, and immediately when an ambulance, and they should know in advance that immediately when an ambulance will be called, that they will tell the ambulance driver or the ambulance commander, I don't know how it works there, or in the emergency center, that there are orders, because once they start to ventilate or whatever, to disconnect, as I said, is very problematic from halachic point of view and from the law point of view. So therefore, everyone that has instructions should have them in a very, that all the family will know where, that if something will happen, chas v'shalom, they'll know immediately, because not the physician is the problem. As I said, the ambulance and the emergency care is the first stage, and many decisions are being made there, and sometimes it's too late.
So Rav Cherlo brings up an important point. There are many times that ambulances have come to the home and someone says, well, he didn't want CPR. But the ambulance, the paramedics who come, if they don't see a form and there's someone who's there who can show them that they're the surrogate decision maker, if someone has stopped breathing, has no pulse, they're required to do CPR. So the most important thing, and in fact, in our living room, we had a folder with Rebecca's Ipui Koach and everything she wanted. And in fact, we had to call ambulances several times. And when we did, we had all the forms there, so they knew exactly what they were allowed to do and not. But if you don't have the forms, they're required to do CPR if there are no forms stating that the person would not want it.
All right. Yeah, so we have to move on to the next session, but I'll just ask one other very practical question about the limitations for a DNR. Is it, for instance, is it only good for X number of years?
So all of these advanced directives in the Ipui Koach as part of the terminally ill law are good for 5 years. After 5 years, you'll get a notice from the Ministry of Health and you'll have to renew your orders, which is probably a good idea because as you see, things change. And if you sort of put it in a folder, you forget about it, and sometimes things change. So it's probably a good idea to rethink these things every few years. And the terminally ill law says you have to do it every 5 years.
Okay.
From our experience, people are changing their mind. When you're 60 years old and you are writing, if I will be in diapers, I don't want to live anymore. And when you are 85 or 90 years old and you have your grandchildren and grandchildren, and it's really not convenient to be with diapers, but you want to stay. And so the idea of rethinking every 5 years, I think, is a very important thing. And I do support the idea that it's not forever and everyone has to renew it when he's getting older and his observation point is completely different.
You can certainly do it before 5 years if necessary.
Okay, well, we're going to move on to the next session because I think some of the questions that are posed may be addressed there. So there we're going to be discussing issues related to dilemmas in nutrition at the end of life. And Professor Sprung, the floor is once again yours.
Thank you very much. So talking about nutrition at the end of life, why is it important for you to know about nutrition at the end of life? In the United States and other countries, doctors and courts include nutrition and fluids as other medical treatments, thus allowing them to be withdrawn from patients based on the patient or their surrogate's request. In Israel, the situation is very different. Food and fluids are regarded as basic needs of any living being, and rather than treatment, and therefore cannot ordinarily be withdrawn. Now, there are many ways to receive nutrition. The best way is to give food through the mouth. This is natural and also has the psychological benefit of tasting the food. Unfortunately, many people may be too sick to eat and have to receive food in different ways. Sometimes feeding is artificial with the help of a tube placed in the stomach or intravenous fluids. Now, I previously discussed Rebecca's desires concerning some treatments, such as being on a respirator or CPR. There are many other therapies that people have to decide whether to receive or not, especially if they may have a terminal illness. These can include surgery, dialysis, chemotherapy, but also food and water, among others. I will try to provide you some general do's and don'ts, but it is important to remember, just as for advanced directives, for nutrition at the end of life, there are no cookbooks or protocols. Every patient is very different. Medical facts and circumstances vary, and most discussions and decisions should be made by the patient and the family together with healthcare providers. Now, here are a few facts that may be helpful. In Israel, the terminally ill law permits a competent terminally ill person to refuse food and artificial feeding. The law requires the staff to make a reasonable effort to persuade the person to eat and drink if he or she refuses. If a person becomes incompetent, the law prohibits withholding food and fluid from an incompetent dying patient. Under these circumstances, doctors can provide food and fluids to a patient who had previously refused them. If, however, the doctor believes that food or fluids would be harmful, perhaps aspirating some food into the lungs, or the patient would suffer getting the food this artificial way, then there is no obligation to provide the food and fluids. Now, I had previously mentioned that my desires for treatments were more aggressive than Rebecca's. Caring for Rebecca for 5 years has changed my perspective, and my wishes now are more in line with what Rebecca's were. Now, as noted previously, Rebecca had lung cancer for approximately 5 years. She lived this long thanks to the aggressive and devoted care she received from her doctors and nurses. But in January, this past January 2022, the situation deteriorated even further. Rebecca was to be evaluated for radiation treatment, but the morning she was to go, we both got up and she told me, Charlie, I just can't go. She had not slept for more than an hour or two for 19 consecutive days. And she said, I just can't go on this way. I need palliative care. We were very lucky, and that very night she started receiving palliative care. And over the next few days, she finally started sleeping. In fact, she slept much more than she had ever slept for years, even before she was sick. So palliative care is good for a lot of things, and certainly for sleep, at least for Rebecca. During the next few months, Rebecca's quality of life improved. As the chemotherapy and other medications to save her were discontinued, she had fewer side effects from them. She still, however, remained with many complications from her cancer, which had spread. These included loss of appetite, problems swallowing, vomiting, and aspirating her food at times. She had difficulties eating solids and at a time mostly ate ice cream, Jell-O, ices, and yogurt. At one time, she was unable to eat at all and had to receive intravenous fluids. At that time, she refused food given by other artificial mechanisms. Now, I'd like to tell you an interesting story that I think is important. During the time Rebecca was having problems eating just about anything, we decided to go to a restaurant with all of our children and their spouses just for a change in scenery. The change of surroundings helped tremendously, and Rebecca was amazingly able to eat not only fish, a little liver, and she actually had a few glasses of wine. Now, I hope I'm going to do better as the projectionist here. Do you see that now?
Yes, we see it.
This is Rebecca at the restaurant with family, enjoying the meal. So sometimes it's good to get out, even if you're in hospice and palliative care. Now, despite receiving palliative care, home care, and hospice care, as the cancer had spread to her brain and spinal cord, Rebecca underwent radiation to those areas to help improve her symptoms. The vomiting improved, as did her appetite, and she was once again able to eat and drink much more. Subsequently, however, when Rebecca once more had problems eating and drinking, she did not want to have intravenous fluids again, nor other artificial feeding. Until the very end, she continued to eat and drink the minimal amounts that she could. Now, I've participated in this educational program because Rebecca and I believe that it's extremely important for people to understand what is available for them at their end of life, to make sure they receive the treatment that they would desire and do not suffer. For those who have not seen Rebecca's video on choices at the end of life that was broadcasted on Khan a few months ago, I recommend that you see it for further enlightenment and inspiration. Now, we're going to put on the chat now. This is the original link to the Khan video, but since then, we've actually been able to put in English subtitles. So if you take a picture of this, we'll send you this link also. You can see, you'll be able to see that video. Now, let me just close this, and I must, before I finished, show you the picture. Now, hopefully the picture, this is the picture of Rebecca holding Barak Legend, our 12th grandchild. I had to get that in. So my main points for this section are that there are many ways people can receive food and nutrition. In Israel, food and fluids are regarded as basic needs and not treatments, and therefore are usually continued after other medical treatments are discontinued. Competent individuals can refuse medical treatments and can also refuse food and water. Incompetent individuals must usually receive food and water, even if they previously refused them, unless this would be harmful or would cause them suffering. Palliative care can improve a person's quality of life and may also include aggressive treatments that are not usually associated with palliative or hospice care. So after tonight's program, when you turn off your computers, what are you going to do about these important issues? I suggest a family discussion to bring you all closer. If not tonight, because the hour is a bit late, certainly within the next few days. Thank you very much.
Thank you very much, Professor Sprung. Your personal and professional perspectives are obviously extremely helpful, and it was definitely a meaningful session that we now turn to Rav Shurlo to also again offer the ethical.
Nutrition is the most complicated issue in ethics, in halacha, in law, and in every aspect. And actually, the main word that I can say about nutrition in the end of life is a fog. First of all, from the medically point of view, we don't know many times if it's necessary. A person, when he's, let's say, with a very, very deep dimension, can stay alive weeks and even months without any kind of nutrition. I'm not talking about liquid. I'm talking about eating, and many times feeding in an artificial way is, first of all, a torture, but it's not only that, it's a problem of pollution. Trying to feed in this kind may cause, without artificial, and trying to feed slowly may cause the food can go to the lumps and not to the right, where it has to go. And we don't know if, as I said, if it's necessary, what is the damage, and we don't know even if, especially in dementia, if someone is suffering from hunger, should it be considered as medicine, like in other states, or it should be considered as priority, take care that you cannot avoid and you cannot stop feeding. And you know, from the Jewish mother, and the saying that eating is the most basic thing of life, it's very, very difficult to know from, as I said, from the medical point of view. It's also very difficult to say from the halachic point of view. If you read what rabbis wrote, let's say 20 years ago, I think that 100% of the rabbis wrote that even if we do agree that we can stop trying to take care, and we're shifting to palliative care, and it's a different way of approach, but stopping feeding is something that is inappropriate and prohibited according to halacha. I think that 100% of the rabbis wrote in these kinds of things. But in the last 20 years, we learned a lot from the medical point of view. We learned a lot reading again and again the sources. And actually, there are different opinions in halacha. Should we say under any circumstances, stopping feeding is prohibited, or you should ask the doctor if it's necessary, if it does good, if someone is suffering, if what will happen if we will force putting in the zonda, so maybe the patient will pull it out, and the damage will be much worse. And when people gave in advance orders, we don't want to be fed in an artificial way, to accept the wishes, and many, many kinds of questions, ethical and rabbinical questions. So these are, as I said, it's a fog, because we don't have a direct answer because of two reasons. The first one, as I said, we don't know. We don't know the medical issue, 100% of it. We know only parts of it. And we don't know the ethics and the halacha appropriate way, how to face this situation, and how to predict it, and how to conduct it, and how to work it out. The second thing is that really in this issue, nutrition, every patient is different. You cannot say something in general because there are so many factors that have influence on the final decision and the bottom line and what to do eventually, so that you can, from my experience as a rabbi, every patient is different and every story is different. But what is important to know, to have a general view. And I think, again, the most important thing to know is that there is nothing right by saying nutrition under any circumstances, and we have to feed, even if it's with power, we have to tie the patient, we have to do that and to do that. That's the first thing that everyone should know, that there are options and there are circumstances and there are cases where the right thing to do is to stop feeding, and not to, and it will avoid pollution, it will avoid suffering, it's not necessary. And I think, as I said, it's so important to know that there are options. Therefore, we have to ask, and we have to discuss and discuss between the staff, between the ethical professions, between the family, between reading the orders, the advance orders, and making the right decisions to this personal, individual patient. That's the first thing I think that is very important to know. The second thing that is important to know, that before running to making all kinds of really dramatic decisions, there are many tiny things that we can do for nutrition. We have to be patient and to feed slowly with a spoon, and all kinds of different things to eat. As we heard before, ice cream has a lot of power, jelly has power. Everybody knows all kinds of powders that there are, unsure, and all. We should not run very fast to make dramatic decisions. And the basic and the most important thing is to be patient and to have and to find a way that we will not have to put in all kinds of tubes and all kinds of technical things that actually are a inconvenient. It's not only that they're inconvenient, it's suffering from them. And as I said, not in many cases, they don't have any reason, unless you say that they're only as under any circumstances, this is you are forced to eat. The third thing that is very important is that many times artificial feeding is causing more damage than advantage. And when you know those three things, you know that even though it seems, how can I think about the idea of stopping feeding? We must check it. It's not the first thing to do. I think that the opinion and the halachic and the ethical opinion that we should, that the default is to feed. But, when you say default, you say that there are so many exceptions and so many reasons not to work according to the default. I think this is the right thing to say, that the default is to continue feeding as long as we are able to do that, but to check again and again if the right thing is now to continue, or it's time to say there's no necessity and no advantage of continuing feeding, and the suffering in forcing and the artificial and the zonta tubes and whatever are worse than stopping feeding. And as I said, when a patient is in a stable situation, it's not that when you stop feeding or stop nutrition, someone will die immediately from hunger. It's a long, long way. And in many cases, much before the hunger will do anything, our relative or even ourselves will die in a patient way and not in out of suffering and being forced to being fed. And as I said, I'll try to summarize, it's a fog. we don't know exactly all the facts, not from the medical point of view, and as I said, not from the halachic and the ethic point of view, but there is an option. And when there is an option, the meaning is that you don't do any automatic decisions, and not decisions in general. It is specific, individual discussion on every patient between the staff, the rabbis, the family, the patient, and many times, from my experience, you come to the right decision, and you actually can collaborate and the whole family and making the right thing for the patient, even though saying that to stop nutrition is very, very difficult from the emotional point of view and also from the philosophic point of view, but there are times this is the right thing to do.
Thank you very much, Rav Shurlo. So we have a bunch of questions and we'll try to get to as many as we can. The first question we'll address is probably could be an hour-long discussion on its own, but regarding the issue of organ donation, can the issue be addressed in the sense of supposing the dying person wants to donate, but the children don't, or vice versa?
I'm not
I
sure.
know that's one of our topics, but we can do that if you'd like.
I'm not sure I understood the question.
So I think that the question of organ donation is too big an issue for this context. But that specific question about if a dying person has a specific wish that opposes the wish of the children, how are these types of things usually resolved?
So I dealt with that for many years. I can answer it now if you'd like, or you want to have, maybe that could be a topic for the next session. Whatever.
I think it's better that we'll speak about it in a different session, because I want to say that disagreements inside of the family is a medical problem, but it's also it's causing a lot of damage after death. And therefore, we, in our policy in the Tzar, in ועשרים, is to try as much as we can that the family altogether will make the right decision, if it will take more time, but when they are unified and when there's one decision in the entire family, it helps mourning, it helps the day after, and it really keeps the family together. That's in principle. But organ donation, I don't know. I want to say I'm the chair. I want to say one thing. I'm the chair of the ethical committee of the government, of the Israeli government, of the organ donation department. So therefore, it's something that I'm very familiar with and I'm very proficient in. Maybe we'll have a special event about organ donations.
Excellent. Okay. Another question: can artificial feeding via IV fluids be stopped once they are started?
Yes. From halakhic point of view, definitely yes. Because this is not active. This is stopping feeding, and it's not. Even though it's very, I'm not sure I'll be able to explain it in English. What is the difference between stopping ventilate and stopping feeding? But it's two different topics. And stopping feeding is not an active thing. It's actually a passive thing that you are permitted to do.
So I could answer that maybe more clearly from the terminally ill law. In general, you can stop an intermittent treatment, antibiotics or dialysis. You just don't start the next treatment. So you can withhold the next treatment, but you cannot withdraw a continuous treatment. So if you're on a ventilator, you can't take someone off the ventilator because it's continuously going. Since the feeding is intermittent typically, then you can stop the next treatment and it's not a problem.
Okay. Another question: will a hospital staff obey the wishes if they were written without a yipoy koach mitmashech?
So again, I had mentioned that the terminally ill law, there are several clauses which talk about legal documents, and the legal documents include the advance directive and the ipoi koach. But if you don't have those things and you have a statement that the family member made, then that's important information. And again, the doctors and nurses and the staff want to do what's best for the patient as the patient would define it. So we're always looking for that information. And if we can get that information from a close family member, we want to get that information. I saw some of the questions in the chat. One thing I want to bring up, which Rav Cherlo mentioned, which I think is exceedingly important. I have, I don't know how many thousands of Zonders or nasogastric tubes I put in. People complain much more of the pain of having a Zonder or nasogastric tube in than even having an endotracheal tube in their trachea on a ventilator. It's extremely painful. A lot of people take them out and they have to be put back in. And it's a real problem. So what you can do, if you have a family member who can slowly feed with a spoon food, you can give as much nutrition, sometimes more than you can with a Zonda or even a feeding tube. The problem in an institution and a nursing home, they don't have the time to spend hours giving food that way. But if you could do that, it would be equally effective and probably better in the long term.
Okay.
I want us to be for a minute a little bit cynical about the staff and the family. The staff will, as Professor Speller said, actually the family doesn't have any official status, but the staff will be grateful to get instructions from the family. First of all, because they assume that the family are the best representatives of the patient. But now I'm saying something that is a little bit cynical, but it's really right. There is a second reason why the staff will prefer to obey what the family says, and that is because they prevent themselves from being sued, doing things that are against the family. Because if they do what the families are asking, so they are rescued. They are, they're safe from being sued as making mistakes or doing wrong things. When they are doing things that are against what the family it says that actually it's what the patient wanted, so they're under risk. So it's also a reason why this, even though the family doesn't have a official position, in most of the cases, the staff will be grateful to do what the family asks to do.
Again, the problem is you have a large family and different people want different things.
Right. That's right.
That is very common, and that's why I cannot emphasize having these advanced directives, having these discussions with your family members so they hear what you want.
Yeah, on that note, there's a question. If the person previously gave a directive not to receive artificial feeding, will that be respected after the person is no longer competent?
So based on the terminally ill law, there's a clause 16, which specifically says if the person is incompetent, even if he previously did not want to receive food, and even if under those circumstances he has significant suffering, you have to give the person, again, food and water, unless it's going to cause suffering by doing that or causing a problem in terms of harming the patient. In the last 2 weeks of life, you have to provide liquids, but you don't necessarily have to provide the food.
Okay. There's been a couple questions asking you to address the issue of PEG and the feeding of a PEG. Is it also okay to cease, as you just wouldn't add the next bag? Is the directive simple?
It's the difference between withholding and withdrawing, and you don't have to start the next bag.
Exactly, but in most cases that we're speaking, PEG is too late. I mean, in most cases that we in Tzohar are dealing, PEG is already not an option.
And usually when patients are in the hospital, PEG is usually not a very good option because there are more complications when the PEG is performed in the hospital than subsequently when the patient recovers and is done in a subsequent time.
Mm-hmm. Okay, this is also a broader question perhaps, but a couple of people asked regarding the halachic perspective on palliative care and the whole concept of giving up, in quotes. What does halacha say about that concept?
Okay, actually, we had a lot of meetings about this issue, and if it was the first meeting, I think we should have started with this, but we decided this evening to do something that is more advanced and something that is more professional. If there will be a need or a request from the audience, we'll make another meeting, and we have already two issues about it. One is the palliative care according to halacha. The answer is yes with a capital Y, but I have to bring the sources and explain why and when and how. And the second thing, we spoke before organ donation, so actually we have the next meeting prepared. I don't want to say, I only said one thing, that there is a point that halacha not only permits doing and moving and converting towards palliative care, but in some cases you must do that, and it's a order to do that and stop. Actually, it's a kind of a torture towards trying to expand life and without any horizon, without any reason.
So in our last session that we did with Nefesh B'Nefesh, we did bring up the palliative care issues. And palliative care doesn't mean throwing in the towel. It doesn't mean giving up. It means not giving aggressive curative treatments, but taking care of the patient's suffering, improving quality of life. And as I had mentioned the last time, there are some studies in patients with advanced lung cancer that when the people got palliative care and did not get the aggressive care, they had not only a better quality of life, but they actually even lived longer. So when you give palliative care, just by getting rid of some of the side effects of the chemotherapy and helping the patient sleep better, eat better, sometimes those patients actually even live longer.
Okay, I think a lot of the comments in the chat open us up to bigger issues that we look forward to exploring in future discussions. And I invite anybody who has any specific questions or even broader questions, they're invited to contact the ועשרים program online. The website is available in the chat it's ad120.sohar.org.il, and you're invited to ask your questions in Hebrew or English. The full recording of this program tonight will be disseminated by email to everybody who registered, and it'll be open to be forwarded to others as well. So with that, I again want to thank Professor Sprung and Rav Sherlow for their insights as always, and we look forward to having continued sessions. Again, a big thanks to the Aaci for their participation, their partnership, and for helping us make this possible. Thank you all and have a good night.
And thank you to our moderator.
Thank you. Laila tov.
Bye.
Thank you.
Bye.